Hello, everyone. Once again, welcome to the first affiliated hospital of Harbin Medical University. And then today, we are going to make this live broadcast in a new branch of our hospital, which is located in the Qunli branch. Today, Professor Gong is going to perform a very complex CTO case with a blunt tip total occluded LED. And please next, I will introduce the leading operator of today, Professor Gong Yongtai. And the second operator is Dr. Sun Danghui, Wang Dingyu, and Dr. Zhao Hongwei. I'm the moderator for today. I'm Cao Yang from Cardiovascular Department. At the beginning, I'd like to introduce the general information of this patient. From the screen, we can see that this is a relatively young male patient. He is 59 years old, and the past medical history and the risk factors include hypertension, and he is a heavy smoker, and we can see that there is a hyperlipidemia. He accepted PCI for the RCA 3 years ago due to the old myocardial infarction. However, he complains the chest pain for 1 week and recently, and admitted to our hospital. And the body check include, we can see that the hypertension is not that well controlled, with a systolic pressure 140 over 94 millimeter mercury. And let's check. We can see that this is a laboratory data, and we can see he also suffers hyperlipidemia. So we have this patient on the well medication control. And ECG demonstrated sinus rhythm with ST segment depression from the anterior lead of the ECG. And ultrasound indicated normal heart function and also the structure of the heart. So our preliminary diagnosis for the patient is coronary artery disease, unstable angina pectoris, and hypertension, etc. So let's have a general review of the angiography that we performed 1 week ago. And this we can see that this is a totally occluded LED with mild to moderate stenosis with the body of the left main. And also we can find there is a very focal severe stenosis in the mid circumflex with OM branch proximal part with some diffuse long stenosis. This is another projection which better demonstrated the stenosis in the body of left main and also the circumflex. From the spider view, we can see that the severe stenosis in the circumflex and left main. Another projection. Okay, so for the angiography from the RCA, we can see there is a very long stenting from the mid distal part of RCA directly to the proximal ostium of the RCA branch. And also there is a collateral flow from the distal RCA through the septal branch to the distal LVD. So we can see that the occluded segment is relatively long from the angiography. It's totally over 20 millimeter. And several collateral flows connected to the septal branch to the LVD. So this might be a potential retrograde case. Okay, this is the still image of the retrograde flow from the RCA to the distal LVD. Once again, I think the audience is well known that our facility is famous for the intelligent artificial visualization system developed by Professor Li Yue. And also we performed the CT angiography before this procedure. And we can see that from the baseline imaging of the CT angiography indicated some long diffused CTO segment in the LED. Okay, this is the general information of this patient. And next, Professor Wang Dingyu is going to demonstrate this CT angiography reconstruction software developed by our facility. So let's check the CT image. Okay, we can see that this is a reconstruction of the general CTA angiography. I think Professor Li Yue has made some live demonstration of this software several times. This is a very unique and very helpful software, especially for the CTO procedure, I think. One thing is that you can detect the detailed plaque distribution as well as composition of the plaque before you touch the patient. So this is of a very great value and the information for you to help you to set up the strategies. How do we perform PCI for this patient? Okay, let's delete the irrelevant arteries and only leaving the, yes, thank you, the LED. And also we can see that at the proximal junction part, shall we, call back the circumflex? Okay, circumflex is there. So one, I think that tough spot for this patient is that this is a blunt tip, total occluded. It's hard to tell where is the entry point of the proximal part of the LED. So from the CTO angiography, we can see that at the proximal part, there is a very, blunt tip, totally occluded. And also we can see the plaque composition is majority is, I think, fibrotic from this composition with a mild calcification at the ostium of the LED. We also know that this kind of CTO with a bifurcation is very high risk of failure from the antegrade because there are some patent, cell branches. Sorry. Okay, let's delete the occluded segment to check the whole information of the, yeah, okay, thank you. So from this one, we can see that this is a relatively long, totally occluded segment, which indicated some difficulty from the antegrade approach. Okay, I think that this is might be the enough information from the CT reconstruction. And later during the procedure, and we can recheck this detailed CTO angiography information. Okay, this is enough information for the baseline of this patient. I think that's next. Professor Gong Yongtai is going to introduce the angiography information and also the strategies for this patient. Professor Gong, are you going to introduce the angiography and also the procedure strategies for this one?
Okay. Good morning, everyone. Today, this case is very, the lesion is very complex because of the opto LED CTO lesion, and we cannot confirm the proximal cap location. And for this case, I think we should try the retrograde approach firstly, and then uh, we build anti-grade approach. And I think the better method of the technique is the reverse cut to recanalize the LED auto CTO lesion. And the risk of this lesion is if the retrograde or the antegrade Y cross the lesion from the subintimal at the opposite opposite side of the carina of the circumflex and LID after stent deform implantation, the large branch may be lost, and it will induce very dangerous complication.
Yes, okay. Thank you, Professor Gong. I think that Professor Gong has indicated some very important and valuable information in this patient. For me, this patient is a relatively very complex patient. One thing is that this is a triple vessel disease patient. Patient accepted PCI 3 months ago for the RCA, 3 years ago, sorry, for the RCA. And we can see several, relatively very long stenting segment can be detected in the proximal and also the mid RCA. And also we found that there is a very focal severe stenosis in the proximal of the OM branch and also the mid part of the circumflex, and the RAD is totally occluded. So we all know that for the CTO, cases, totally revascularization is of key importance for the prognosis of the patient. So we can see that before we start this kind of PCI procedure for the LVD, Professor Gong just performed this kind of PCI for the circumflex first to, I mean, guarantee the safety and all, as well as the prognosis of the patient. So before we work on the LVD, first, we use a balloon to dilate the focal severe stenosis of the circumflex, and one stenting has already been put in the mid part of the circumflex. And later we may check the angiography as well as the IVUS image of the circumflex. So it's well expanded and no dissection. So I think that this is of key importance for this patient to make the patient stable as and also the safe during the next procedures for the following, no matter it's antegrade or retrograde. We also notice there is a relatively very big OM branch in the circumflex, and however, the diameter of the OM branch is relatively small.
Across.
We checked with bilateral angiography as well as the IVUS image. So this kind of a small, vessel is not suitable for the stenting. So we performed the PTCA, and later we may check whether DEB is available for this small branch or not. So after this kind of preparation for the circumflex, we move to the RAD. Firstly, we use IVUS in the remus branch to make automatic as well as manual pullback to check the information of the proximal entry point of the RAD. So, okay, next maybe we check the image from the remus pullback first. And we can see that the proximal entry point of the RAD is of key importance in this patient. We need to detect whether this kind of proximal cap and also entry point is correct or not, whether there is any potential, hypothesis, possibilities to make the antegrade puncture. And also, just like Professor Gong indicated, that it is of key importance for us to identify the retrograde wear, retrograde wear upgoing to make sure whether it's through the intraplaque or through the other part of the vessel to avoid some very high risk potential, intraplaque tracking through the left means. And also another very important information in the patient, I think, is that to identify the plaque composition in the CTO segment, which we applied the 3D reconstruction software to detect the majority of the CTO segment. There is no severe calcification. I think this is one good information for this patient because we need to avoid some severe calcified information to make the potential very,
ACP.
high risk puncture to goes into the subintimal space. At the beginning, I think Professor Gong just checked the proximal cap of this patient to make sure that everything is at the correct position.
你别在这儿，I to the ACP，这里面有东西啊。
And later that we identified the proximal entry point of this patient, we move to the retrograde approach. So one question is that why should we perform, retrograde first, or should we try from antegrade to make some antegrade puncture, or maybe a dual lumen microcatheter to see whether it's available or not. So in this patient, I think that it is of high risk to make antegrade, blind puncture in this patient, because one thing is that from the CT angiography reconstruction software, we identified it's a blunt tip. There is no, macro channel leading to the occluded RAD or etc. like this one. So I think that blind puncture is not a good choice in this patient. And another thing is that we can see the collateral flow from the distal RCA through the septum to the distal RAD is a relatively several, choice for this patient. So we can take some time to review the retrograde wear. Okay, let's take the some time to review the IVUS image of this patient. I think that it is of good importance in this patient to check the imaging. So this is the circumflex. We can see the pullback of the circumflex with a diffuse severe stenosis. We can see that this is a relatively 2.5 to 7.5 vessel as a mid part of the circumflex. And this is before the stenting, after the pre-dilation. Since this is a very severe, heavy plaque burden and long, relatively diffuse lesion. And let's check the final stenting, instant
PPT
result of the circumflex.
microcleft.
And now we are checking the instant result of the circumflex after stenting. So we can see the distal part of the stent is well expanded. There is no hematoma, and also we can see that the whole severe stenosis has been covered. So this is of key importance for some preparation before you touch the LED. And this is a pullback from the Remus branch to check the occluded LED proximal entry point. So we can see that on the left, currently the IVUS imaging catheter is located in the Remus branch. And this vessel, relatively very large vessel on the left side with a wire in it, is a circumflex. We can see it's a circumflex joining into the left main. And on the right side, this is the occluded LED. We may check later very detailed information with a manual pullback. Okay, we can see that this is a occluded LED. And there is a very hint, not so clear. We can see that something, okay, we can see it seems to be a very small entry point from the anti-grid. However, I want to emphasize that this kind of, how to say that entry point, however, is on the side part. It's not in the center part of the vessel. It's of a relatively high risk from anti-grid of going into the subintimal space because we can see that this kind of entry point is very close to the intima and also with a very sharp and tortuous angle of the proximal RAD. This is of a high risk from the anti-grid. Even though that we are trying the anti-grid approach later, maybe, and I think that the bilateral angiography and also the dural lumen macrocatheter is of key importance in this patient. Okay, now we can see that Professor Gong is working on the retrograde approach. We just mentioned that this patient has several choice for the retrograde entry point. And from the distal part of the RCA, I think it's highly likely to be the
No,
PRV
cannot be
branch
changed.
that several connections has been made through the distal RCA to the septal branch and goes up directly to the septum. And actually, we spent some time during the choice identification and also the wire upgoing through the distal connections to the septal branch. And we can see that currently the wire is in the relatively distal one connection of the distal RCA branches collateral flows. Actually, we made some, supraselection angiography with the microcatheter and also the floating of the wire several times to trace each of the connections to the septum collectors. And finally, this distal one is relatively the most smooth, not so tortuous, and relatively with a good, direction one. So currently, we can see that the part of the wire has already been going to the septum. And I think that it is good for us to review some devices that we have been used for the retrograde approach. I think that at the very beginning, we were using a microcatheter of, I think that we can see there is Corsair microcatheter with a very good direction from the tape. We can see that several, wires has been combined together to increase the support of this microcatheter. And also, I think Corsair is famous for its unique usage that with rotation to push the microcatheter to go through. The tip of the microcatheter with some hydrophilic coated with 60 centimeters and also that's with a relatively very good visualization at the tip part of the microcatheter to help you to identify the direction as well as the how to say engagement of the microcatheter. The retrograde wire, first I think that we used a thin wire. However, it failed to entry the retrograde connection part, and then we switched to filter XT wire and then a SU03 wire was used. And eventually we can see that it goes into the mid part of the septum. However, we want to emphasize, and later we may check the bilateral angiography of this patient because this kind of connection from the distal RCA through the septum to the distal RVD is not that clear. The relatively flow is not so clear. Maybe a CC level 2 with some tortuosity at the mid part of the septum. So we can see that where outgoing, so retrograde is meet some resistance and have some difficulties. And also, I want to mention that the retrograde microcatheter, we have several choice during some clinical, usage. For the cochlear microcatheter, we just mentioned is a relatively very good, very popular microcatheter for the no matter it's antegrade or
1.00.
retrograde. We can use it as a relatively advancing with rotation and improve its crossability significantly. Rapid clockwise and counterclockwise rotation of the microcatheter uh, with both hands with no more than 10 turns in one direction before this kind of releasing is a trick of this microcatheter.
Hmm?
And also for this patient, IVUS guidance is of key importance because we know that for this kind of patient, the making sure the whole wire is in the true lumen is of key importance. And during our clinical usage, I think that intravascular imaging is well, applied for the clinical usage. And several indications can be, how to say, implied for the IVUS image clinical usage for the CTO lesions. One thing that I think that the most popular usage of this intravascular imaging is to identify and also have a good location to realize where the wire is. So one thing is that to identify the proximal cap location in cases with a blunt tip CTO segment, especially in this case. And we just make a pullback from the remus branch to identify the proximal
Okay.
cap as well as its
Patient
plug composition and
location.
distribution.
Ask.
And the second thing is that
Mm-hmm.
and the second thing is that to confirm the antegrade wire has engaged the CTO lesions as well as location in the CTO segment, and also facilitate the reentry into the true lumen during both antegrade and retrograde crossing, confirming that the retrograde guide wire has entered the proximal true lumen before externalization, and also determine the appropriate balloon size for potential card or reverse card techniques is also the clinical usage of intravascular imaging. And I think that one very important information in this patient that during our clinical practice is that we need to pay very close attention to the situation of the left coronary artery because we need put an eye on the left main body always because we notice that there is a relatively, I mean, moderate to severe stenosis with moderate to severe stenosis at the left main body, and we checked with the IVUS that currently the minimum lumen area is over 4 millimeters square, so we do not worry too much about the stenosis. However, with this kind of retrograde guiding catheter at the left coronary artery, we should always pay close attention to the situation of the left limb body because this is a potential hazard ratio, a risk for this patient. And I think that we may take some time to check the left limb plaque composition and as well as its distribution at the current situation, since we can see that Professor Gong is working on the retrograde approach.
Give me another
Okay, this is the proximal
profile.
part of the circumflex, and we may check the left main body. Okay, let's make a.
2.0.
Okay, I
Follow.
think that we have already goes into the left main. We can see some mad plaque composition on the
Hmm?
bilateral, on the side part of the left main. There's some fibrative plaque, and also, okay, this is the left main body plaque. We can see some mild intima dissection, but we don't worry too much about it because we can see that currently the residual lumen area is okay. Here is some, so it's over 5 millimeters square with some mild, tissue dissection, but it's not a big issue. And also, we can see that during the retrograde approach, we know that uh, where upgoing is of key importance, and we can see that Professor Gong has managed to cross the most tortuosity part of the septum branch. And the next part that we are trying to use the microcatheter to pass through the whole septum branch to the distal LVD. However, we can see some tortuosity at the mid part of the septum. Here we meet some resistance, I think, during the retrograde approach of the macrocatheter passing through. Macrocatheter is of key importance in the retrograde approach because it's a, how to say, we call it a body, the body of the retrograde wear of the macrocatheter, which can increase the support of the retrograde wear in passing through the whole vessel. And also we can see that larger macrocatheters such as the Corsair facilitate collateral crossing, like I mentioned from the beginning of this procedure. And also the other relatively smaller microcatheters, such as Caravel, we have
IVUS ACT.
Turpec LP and the Frank Cross, etc., may be easier to deliver, especially through the smaller caliber epicardial collaterals, but provides less support for the crossing complex, for example, heavy calcification lesions. And also, microcatheter from the retrograde can confirm that the retrograde wear has crossed through the collateral into the distal true lumen, and also make some tip injection to confirm the distal part of the wear is in the true lumen or not. Sometimes the microcatheter through the retrograde approach has a function of dilate the septum collateral branch, this kind of function after passing through to make the, following the rest relatively easier. So, Professor Gong, what retrograde microcatheter are you using currently?
Uh, Firstly, we used Calcium Pro, but it cannot cross the collateral since the retrograde wise is successfully crossed the collateral. So we changed the front cross,
Mm-hmm.
and the smaller tip of the front cross maybe facilitate the crossing, but unfortunately it cannot cross.
Mm-hmm.
Then we used a 1.0 balloon
Mm-hmm. Mm-hmm.
to, to, to try to cross the collaterals, but it also failed.
Mm-hmm.
So now we will try to change
Mm-hmm.
the different collaterals in order to get the microcatheter across the uh, retrograde approach. If the retrograde microcatheter cannot change the target vessel, the subsequent step will become difficult.
Mm-hmm. Mm-hmm. Okay. Okay, thank you, Professor Gong. I think that we can see that Professor Gong is also working on the retrograde wire crossing. I think that for this patient, the most, tough spot is that this is, we just emphasize, this is a blunt tip, totally occluded LED with no clear entry point from the antegrade. And also another very tough situation is that this is a very typical CTO, case with a bifurcation. We just emphasize that a CTO case with a bifurcation is with multiple,
UC.
antegrade failure,
When
indicators.
you see.
Several things can be found that, for example, the patient with a branch failed to engage to the CTO because the occlusion of the set branch is relatively blunt tip. There is no entry point. And this kind of phenomenon is caused by the, how to say, the blood flow from the retrograde because caused the plaque composition and also the development goes up to the bifurcation site. And also the insertion of a guide wire into the set branch, which is difficult, can act as a marker for the, how to say, the set branch origin. And also we can try to use a balloon inflation in the set branch or non-inflated balloon and can block the wire.
No,
And also we can try to use a dual lumen microcatheter from the anti-grid in this case. However, it's not a guarantee
no, no, no.
for the right entry point puncture. And also we know that if we use the anti-grid wire approach and we go into the subintimal space for this case, it's highly likely and a failed anemia indication in this patient. So we can see that we are still using the retrograde approach as the first choice in this patient because there are several predictors for the antegrade failure in this patient. Another very important thing in this case is that we can see that choosing and also the selection of the good and relatively the right collateral flow from the RCA is a key importance in this patient because we can see there are several collateral flows. However, we tried them one by one, but none of them currently seems to be the right connection. We can see we choose the one in the middle, the relatively most, how to say, the clear, relatively straight one. How to say, the wire goes into the mid part of septum, but it have some resistance and some difficulty of going up continuously.
I will view the imaging.
Okay, let me play it back for you.
Okay. Next. Next.
You mean the previous one? Oh, okay.
Just we cross the segment collaboratory, but unfortunately the retrograde microcatheter cannot cross.
So did we try the how to say the caravel microcatheter or change to another catheter to try to
We'll
go?
change another.
Mm-hmm.
This the proximal
Mm-hmm.
maybe a good choice.
Okay, so you think that the one proximal to this choice? Mm-hmm.
But the proximal sand branch is closed to the distal
Yes, distal
pad.
yes CTO segment. So you need to make a very sharp turn after you go through the septum branch.
Yes,
Which is a relatively difficult choice.
very complex.
Mm-hmm.
Okay, I will
Okay,
try.
so I think that Professor Gong has made a very good demonstration of retrograde crossing as well as a macrocaster crossing. I think that for the retrograde we have several choices. Some high volume CTO operators like Professor Li Yue and Professor Gong Yongtai, they have their own unique, how to say, habit and also their choice of retrograde crossing. I think that is the most often asked question is that what wear choice and also the tape band is best for the retrograde wear. For me, I think that for the collateral, retrograde wear crossing, the most often used, I think that is a contrast guided and surfing. When you meet in a very severe tortuosity with the collateral flow, you can try to let the wire move and go with the heart cycle. You do not manipulate too much with your hand, but you just, do not drill too hard with your hand, but you just let the wire flow with the heart movement. One trick is that you use the wire to make it go automatically by itself into the collateral flow. And also the wear choice, now we know that nowadays we have several, choice for the retrograde wear. We have a 203 very, good, very good responsibility, and also very good, how to say, manipulation, this kind of wear. And also the tip band is very important for the retrograde wear. I think the most often used is 0.8 millimeter or 1 millimeter with relatively quite shallow. something like 20 to 30 degrees, although some morphetors use 90 degrees bands to allow for tracking very small, very sharp angled tortuosity collateral flows. I think this is of key importance. And we can see that Professor Gong is trying to choose another collateral flow as a more proximal part of the this branch. It's relatively okay. We can see that we make some progress. It's relatively very smooth. But another thing is that Professor Gong just mentioned this collateral flow is close to the distal, distal cap of the CTO segment. So we need to make a relatively very sharp turn after we cross the wire. Let's check whether this retrograde wire is a good choice or not.
A little contrast. Okay.
Okay, I think that we have already goes into the CTO segment. Okay, I think we made some progress already. So, Professor Gong, what's the retrograde wire you are using currently?
The Xeon.
The Xeon wire.
That we commonly used the retrograde wire. Next, we'll check if the retrograde microcassette can cross the collaterals to get the distal target vessel. If this successful, we think we will make a good progress.
Yes,
And
I think
then
that.
we are trying a retrograde Y.
Okay, that we can see Professor Gong has managed to pass through the microcaster through the retrograde approach. And I think that this collateral flow from the proximal part is a relatively better choice compared to the distal one. We can see although the earlier that our attempt from the relatively distal part of the connection to the septum to the distal LED is relatively larger in the diameter and better flow. However, we can see that there is some tortuosity and also some resistance in the microcaster crossing. So we can see that from angiography, it's not 100% guarantee to give you the, how to say, the very key important information of this kind of a collateral flow channel selection. And we can see that relatively proximal part of the collateral flow is not so good in the diameter and also nor the flow. However, we can see that the wire crossing and also the retrograde microcaster crossing is smooth. And like Professor Gong just indicated that we managed to pass through the retrograde wire. And next stop, we need to try the retrograde procedure. Okay, I think that this distal part of the microcaster has already goes into the CTO segment.
Give me a Gaia one. Gaia second.
Okay, so we can see Professor Gong is going to use the Gaia family wire for the retrograde puncture. We know that why do we choose for the retrograde approach? There are several indicators. One thing is that we always understand the CTO segment, the distal cap of the CTO segment is relatively softer and not so dense in the composition compared to that of the fibrous cap and the CTO segment from the antegrade because of the blood flow and also the hemodynamic function. So that retrograde puncture is always relatively easier compared to that from the antegrade. Okay, we can see that the retrograde microcaster tip is very close to that of the proximal and CTO segment, occluded segment. Just like Professor Gong indicated that one very important thing is that try not to use the retrograde, stiff wire goes up too much after you make the puncture, because there is a potential high risk of a retrograde wire goes into the subintimal space. So AGT technique is of key importance in this patient, and Professor Gong has just emphasized that after we make the retrograde puncture, the AGT technique might be a potential choice in this
A little
patient.
contrast. Yeah, yeah. Oh no.
Okay, we can see that the retrograde Gaia third, right, is trying attempt to make the puncture. How about
A little
we?
contrast.
Okay, how about
Oh,
we try? Okay, I think the direction is relatively okay.
no.
How about we try the spider view or something? So we can see that this is
Fine.
a relatively potential risk that we just mentioned. The retrograde wire crossing is of a potential risk of a wire goes into the subintimal space, and this is not a disaster that we cannot handle or tolerate. Because if the retrograde wire goes
And
into the
here,
left in body
lunar
in the subintimal space,
micropivot.
and we are using a balloon or something to dilate, and then this is a potential disaster because we are taking the high risk of losing the circumflex, which is a disaster for the
Double.
patient. For the distal prognosis of the CTO procedure, here some manuscript update I think is necessary for us to understand. One thing is that the complete percutaneous revascularization on in improving long-term outcomes of the patient with a CTO and a multiple vessel disease. Just like in this patient, we recanalized the RCA, we recanalized the circumflex, and now that we're performing the recanalization of the LVD, so that this kind of triple vessel disease and also the full revascularization is of key importance for the prognosis of the patient, which is a manuscript published in 2021
Wow.
with a total of 558 patients with a CTO
Oh,
and multivessel disease.
yeah.
And another thing is that compares to the different vessel CTO procedures, the LED total occluded case is of key importance because there is a single high volume sensor, I mean LED CTO PCI, uh, mm, indicated that LED CTO PCI, I mean successful recanalization was associated with over 92% of overall survival at 2 years with no difference in survival between patients with or without ischemia cardiomyopathy. And also the LVD CTO-PCI was associated with an absolute 10% increase in the left ventricular EF value at 9 months in patients with ischemic cardiomyopathy. And this is a manuscript published in the American Journal of Cardiology in year 2023. So we know that this kind of recanalization of the LVD and as well as the LVD, triple vessel disease is of key importance. So maybe that we need to stabilize a little bit for the patient before we continue this procedure. However, we noticed that, okay, I think the situation, atropine 1 milligram. I think that situation of the patient has recovered very much. So we need to avoid some deep engagement from the retrograde wire. And also we need to test the flow. I think the flow is relatively okay. So here is some, I mean, indications for the medication usage during the procedure for vasodilators. And we have nitroprusside, which is most often used. And also we have nitroglycerin, nitroglycerin, and also the verapamil. So this kind of a medication is of
Atropine.
atropine 1 milligram plus IV. Atropine. So we can see that this kind of a medication is often used in the clinical usage. So we need to pay attention to the retrograde flow and then as well as the antegrade flow. So like I just mentioned that we can see. Okay, let's check some questions from the audience. Why have you put it where? Okay, this is a good question because one thing is that there is a severe, very focal severe stenosis in the circumflex. And also putting an wire in the circumflex is of key importance in maintaining the right position as well as avoiding the too much engagement of the guiding catheter. So this is a question from the audience. Why do we put in the wire in the circumflex? This is a really good question. Thank you. So like I said, first we perform the PCI in the circ, and also having a wire in the circ is of key importance in maintaining the right position of the retrograde guiding catheter. And second one is that has your imaging reconstruction software been commercially developed? Yes, thank you for your question. Thank you for your concern to our software. As I mentioned, this software is a 100% domestic. It's developed in China, and we are developing this software. And also we are trying to make it commercially. Thank you. Yes, I hope that one day and not far in the future that this software can be applied in the clinical usage. And also of key importance is that it can help the procedures, help the surgeons to develop, to increase their success rate, and as well as to make the prognosis of the patient.
Give me a
The third thing is that are there any CTO for which you do not use contrast lateral? You do not use contralateral injection. Okay. I think that this is a very interesting one. For one thing is that the contralateral injection is, I think, relatively very important information because, for example, in this one, antegrade injection is of very important usage for the antegrade procedure. So retrograde and contralateral injection is of key importance to telling the information of the distal part of the, how to say, CTO segment, and also checking the collateral flows, the information. And finally, what are the risks of trying antegrade approach in this patient? Thank you. I think that we have made some explanation during our demonstration that this antegrade attempt, one thing is that there is no clear identification or any hint for you which direction should be punctured. And another thing is that there are, for example, a reamers and a circumflex. This is a trifurcation. So if you cannot make the right puncture, it's highly likely that the antegrade, very stiff wire, is going into the subintimal space, and which we do want to avoid, because if we make some very severe hematoma or dissection from the antegrade, this is not a good thing, because it's a very strong indicator for antegrade failure, and also that may make some severe damage to the circ or reamers, which we do not want to see. Okay, we check maybe some slow flow for the circumflex, and we might be giving some vasodilators. Yes, natural proceed or necrogranule. 尼可蒂尔或者是橡木纳。And also, Professor Gong, we have some necrogranule, which is favorable for the slow flow and have no effect for the blood pressure and also the heartbeat. So this is, like I said, that we need to put an eye on the left coronary artery, always check the information and situation of the patient. 看看不是原来有血肿啥的也行，看看是不是原来有血肿也行，回旋至上，先给药，给尼可蒂尔也行。So that we can see that this patient is triple vessel disease. We perform the PCI for the circ and RCA. There is a very long, relatively long stenting segment in the RCA. So that this morning earlier, we recognized the circumflex, and also we noticed that this very relatively big OM branch. This relatively big OM branch has a very, severe stenosis at the ostium and also the proximal part of the OM branch. So we make a PTCA and also try to recover the flow of the OM branch. And now we are using a medical catheter to give some high selection vasodilator for the tip of the circumflex. And like I just mentioned, that the natural prostate and natural necrogranule is often used for the clinical usage of the CTO procedure because we can see that for the CTO cases, there is always high plaque burden and also a lot of attenuated plaque in the clinical practice. So we should always try to pay more attention to the patient during our clinical indications. Okay, we can see that the situation of the patient is relatively stable. The blood pressure is fine, the heart rate is fine. So let's check the information.
Okay, so
I think for this case, we already know that this is a very tough, triple vessel disease. Although that for the JCTO score,
okay.
maybe it's only a 2 score because there is it's only the first time attempting from the LVD. However, it's, the occluded segment is over 20 millimeter. It's a blunt tip,
Yeah.
and there is no severe calcification. However, we know that Professor Li Yue has just indicated from the previous operation that the JCTO score might not be so sensitive in the predicting of the
Later contrast.
30 minutes, for example, procedure success rate during the clinical usage. So Rector score based on the CT angiography might be potential, advantage in the clinical usage. And for this patient, the JCTO score is relatively higher. It's a JCTO score 3 or 4 case, so it's more difficult compared to the JCTO score, Rector score. We noticed that Professor Gong has just used an Gaia family wear to treat.
Little contrast.
So we noticed that. So we can see that Professor Gong has just used some Gaia family wear to make the retrograde puncture. And also we know that Gaia family is of good usage in the clinical usage. It's a relatively very good wire with a spring coil at tip of 1 millimeter, and also it's a pre-shaped of 45 degrees. Okay, I think that this is a good time for us to check the IVUS image of this patient to have some detailed information of the situation at the, for example, left min. Okay, let's make a pullback. Pulling back. Okay, I think that the situation of the left min has some change. So maybe Dr. Gong, I think that one stand as the left min is a good choice. What do you think?
Yeah.
Okay, so this is like just we said that this
Low.
is yes, maybe one cent at the left min is important. Okay, I think that after dilation, okay, let me check the diameter of this left min. So this is just like I mentioned, we should always keep an eye on the left min situation and always keep the left min body patent. This is of key importance in our clinical practice. Okay, Professor Gong, I think this is a relatively big left min. However, the circumflex is not, osseum circumflex is not so big. So I think how about let me check, maybe over okay. How about 3-5 stand, 3-5 stand from the osseum circ to the left min? What do you think? 3-5 stand.
3, 5.
Okay, 3-5 stand. I think by let me check. Okay, we take our time and okay, 3-5 by 24, 3-5 by 24 stand. I think from the ostium of the circ to the left min body. So this is of key importance. Okay.
Sorry.
Okay, now we are putting a 3-valve stent from the osseum of the circ and to the left limb body directly. Okay, so maybe proximal and the identification location is a good choice. Okay, currently the patient is in stable situation. We can see the pressure is okay and the heart rate is okay. And next, we are going to put in stent because we can see that the situation in the left limb has changed. So one stent is unnecessary for this patient. 近端定位就行，不用看远端了，直接进主干开口，主干开口可以直接就释放。Okay, I think we are trying to make some precise location of the circ. 近端定位就行，不用看远端了，挤的不要太大，主干开口盖上就可以释放。Okay, we are trying to select the good projection of this patient. 能看清吗？不行就还上，可以吧？啊，对，6。Okay, we are opening the stent. What, 6? Okay, 6. Okay, I think that stent is well expanded. Maybe we pull back a little bit and open it again. Okay, I think this is a good flow. We recognize the flow of the patient. How about the 3-valve NC balloon first? Okay, test a little bit. Okay, 3.5 NC balloon, please. 3.5 NC balloon. Okay, the stent has been well expanded and we do not worry too much. So this is a potential high risk that we have been always emphasized through the whole procedure.